seeking CCO services, they are first assigned a Care Connection specialist. This is someone who works within our Care Connection department, which is our intake and enrollment department. And this is the person who will work with the person through the duration of most of their pre-enrollment process. So one of the initial items that's first evaluated by the Care Connection specialist is to determine if the person who is seeking CCO services already has Medicaid established, or if they are going to need to access Medicaid for the first time. So for folks who are identified as having a need to access Medicaid for the first time, the Care Connection specialist explains that process to the person. Following the establishment of their OPWDD eligibility, because that is something that will be worked on first with the person, once that's established, then the person is going to be assigned to work with one of our Medicaid eligibility coordinators, who's going to work hand in hand with the person to gather all the necessary information and supporting documentation that they will need to complete that initial Medicaid application. So that Medicaid eligibility coordinator really then starts to work hand in hand with the Care Connection specialist, keeping them posted all along the way. So just so folks are also aware that right now we are experiencing about up to 4 months or so to receive a response after submission of a Medicaid application. So we've seen that time frame can be a little lengthy, depending on the Medicaid office, but that has generally been our experience as of late. Parental deeming process to access Medicaid. So that is in the event a child is seeking enrollment into the CCO. So for folks who are not familiar with this, these are for children who do not already have Medicaid. They're seeking enrollment and may need to apply for Medicaid through the parental deeming process. So if you're not familiar with this, this essentially means that part of the application process, as part of it, the parent's income can be waived by the child applying for OPWDD HCBS waiver. And that would happen in the pre-enrollment status. And once OPWDD approves that they are eligible to enroll in the waiver, and they have went through the period of justification, they've sought out alternative services, they would then receive a letter of approval to enroll the child into needed waiver services. I just want to note here too that there is nothing to waive the child's income. So for example, any income that comes directly to the child, such as child support, if they receive Social Security benefits, or income they may receive from a trust, is counted as income for purposes of the Medicaid application. So for children who are identified in this category right up front, they are assigned to a specialized Care Connection specialist, and they complete specialized tasks associated with that parental deeming process and the HCBS waiver application process. Once that approval is received from OPWDD, the child's pre-enrollment case is then connected with the Medicaid eligibility coordinator. They will also work to complete the Medicaid parental deeming application process with the parents for the child. And this too, as I mentioned before, similar timeframes that we are experiencing after submission, this too is taking upwards of 4 months to receive a response. Moving on to initial Medicaid approval. So once that Medicaid approval is received, the Medicaid eligibility coordinator then completes that warm handoff back to the Care Connection specialist. So now at this point, either the Care Connection specialist or the specialized Care Connection specialist will then begin to complete all the remainder of the pre-enrollment tasks so that we can successfully enroll the person in our CCO. Next slide, please. So maintaining Medicaid post-CCO enrollment. So now the person is enrolled, okay, and now they're going to have to maintain their Medicaid. And so let's get into a little bit of the care manager responsibilities in maintaining Medicaid. So ultimately, care managers are responsible for assisting with and ensuring Medicaid benefit recertifications are completed both accurately and timely. So for those with SSI benefits, Medicaid renews automatically, so there's no action necessary from the person or the care manager. But for all others, Medicaid must be recertified annually. And it is the expectation that our care managers are the lead in working with the person and their rep payee to ensure the recertification application is completed and submitted. Expiration. So in these situations, Medicaid is going to expire annually. Monitoring these expiration dates is extremely important. Our care managers have multiple resources within the CCO to monitor and prepare for those upcoming Medicaid expiration dates. So in addition to having Medicaid information accessible in both the Choices platform, it's also accessible in the person's CCO electronic health record. Information is also shared with each individual care manager and their supervisor on a monthly basis for upcoming Medicaid expiration dates. This is where we always want to be very proactive with making sure Medicaid is recertified timely. Part of that includes an automated Medicaid expiration reporting. So care managers receive an automated individual report, and that provides information on Medicaid expirations to our care managers in 30, 60, and 90-day format. This information comes directly from Seek, which is an automated feed that is accessed by the CCO that comes directly from ePaces. So depending on which category the person is in, whether they're in Medicaid's coming due in 30, Medicaid's coming due in 60 or 90 days, instructions are provided to the care manager on actions they should be taking within those timeframes. So for example, if the person is in that 90-day bucket, we're making sure care managers are being advised they should now be actively speaking with the person and their rep payee or somebody who supports the person to help them with their Medicaid and benefits about that upcoming expiration. And really at this point, we want them to be on the lookout for that packet coming in the mail in the next couple weeks. And this is where we're advising the person that as soon as they receive this packet, they need to contact the care manager immediately so we can begin assisting right away. That way there's no disruption in benefits. So these reports that we give to our care managers occur on a rolling basis. So for instance, the folks who are in the 90-day bucket this month, next month, when they get the report, they're going to move to the 60-day bucket and so on. And that helps us keep tabs on where folks are in their recertification process. Now, we do have many folks who live in certified residential settings, and there's some expectations there that we just want to make sure folks are aware of as well. So in situations where the person is residing in a certified setting, and the care manager has confirmed that the provider will be taking that responsibility for completing and submitting the application, our expectation is that the care manager is responsible to collaborate with you as the provider, with the benefits department to validate and confirm that the Medicaid application has indeed been completed and submitted. So care managers, you could expect they may ask for a copy of the completed application. That's important for us to keep in the person's record, just as confirmation that this has been completed, just so we're doing our due diligence on our end, even if another party is taking the lead with the person to do that application. And that same process applies if the member themselves, the family, a rep payee, or another party authorized by the person has requested that the care manager does not provide that level of assistance and that they're confirming that they're taking responsibility for completing and assisting. We want to just make sure that the care manager is still staying in touch, making sure that they do not need any assistance and confirming that it has indeed been submitted so we don't see any disruption there. Okay, next slide. So care manager training requirements and resources. So first bullet here about standard operating procedures and quick guides. So something folks should know is our care managers have access to a wide variety of standard operating procedures and quick guides. These are a combination of resources that give our care managers step-by-step guidance on how to complete a wide variety of care management tasks, inclusive of accessing and maintaining Medicaid. So most notably, there is step-by-step guidance on how to complete a recertification. So this will go through step-by-step how you fill out the form, documents that are needed, things that have to be discussed with the person in order to have that research completed accurately, and also how to handle circumstances when Medicaid has lapsed. Internal training and resources. Right now, we're always working to enhance our training and our competency with our care managers in the area of benefits and supports, because there is a wide variety of things to know. So we are working with our learning and development department pretty much on a consistent basis to always work to expand our library of resources that go beyond just basic insurance needs, and to be able to provide more detailed resources for the wide range of benefits and entitlements that are out there and available to folks. Our goal with this is to really have a workforce that has a real enhanced, well-rounded knowledge base for routine benefits access and maintenance. One thing, we've discussed with other CCOs and something OPWGD has acknowledged too, that we know that going through the pandemic with COVID really has had an impact on this area and this learning curve for folks across a lot of service systems. During that time, research were being done automatically. So a lot of people who came into the field at that time, didn't have the same advantage as folks who were doing this routinely before. So that's something we've really wanted to have a keen focus on, making sure we're continuing to provide that training and those resources to all of our staff. In addition, something new we're offering this year is going to be different seminars that'll be offered internally to our care managers as a training enhancement and supervisory staff. That'll be on different benefits and entitlement related topics that will just enhance that knowledge base for all of our care managers. In addition to what we offer internally, there are OPWDD required benefits trainings as well. So just so folks understand what is required for our care management team here, in addition to those internal resources, these are very clear regulatory requirements for benefits trainings that are delivered by OPWDD. So these trainings are offered on the New York Statewide Learning Management System, or as everyone here is probably more familiar, referred to as SLMS. Trainings are delivered remotely. They're a combination, though, of on-demand training, so things where I can just go on and I can view that training at any time. And then there are some that are only offered live. So those are the ones that the care managers have to pick a date, sign up for, make sure they sign up for those before their expiration date. And those training topics include a wide variety of things. It includes training on Medicaid, Medicare, Social Security, SSI or Supplemental Security Income, personal allowance, and SNAP. And then depending on that training topic, they're either completed annually or every 3 years. So benefit support for our care managers is also something that we offer. This is in addition to training and our written guidance for our care managers. Each CCO also has available Medicaid eligibility coordinators, who I had mentioned earlier, who support in our pre-enrollment process as well. They're available to support our care managers really with a focus on unusual or more complex situations that are related to Medicaid and other benefits. So we have an internal process here at the CCO that care managers follow, and that is so that there is a good evaluation within the supervisory chain to ensure that the situation really rises beyond something that's typical and routine that can be handled within the care management team and their supervisor. And if appropriate, after review of getting that request, then a Medicaid eligibility coordinator would be assigned to the care manager, and they'll work directly with them to assist with rectifying the issue for the person. Next slide, please. So inactive Medicaid and the role of the care manager. So inactive Medicaid notification. So I had mentioned earlier that our care managers are receiving 30, 60, and 90-day notifications for a person's Medicaid for their upcoming recertification date for those on their caseload. But in addition to that, if anyone that we are supporting here is identified as having inactive Medicaid, they'll also receive a separate automated report indicating who is currently inactive. And care managers are expected to immediately start working on rectifying the issue if they were not previously aware. Now, we do everything we can to ensure Medicaid is active at all times, but there is there are a variety of reasons that Medicaid can become inactive. The most common is there is some sort of lapse relating to when that Medicaid should have been recertified and that expiration date. In some cases, nothing was really done wrong. Everything was completed timely and accurately. We might just be waiting on DSS or HRA. We've seen some definite lag times with getting the approval back or the approval of the recertification timely. So those are usually the easiest to rectify and will be reinstated without any type of gap or anything of that nature. But there are other reasons. They could range from coding issues, an overpayment issue, spend downs that the person might have, complexities if they are in marketplace Medicaid, which could cause some issues, particularly with waiver services, if that is an issue there. And there could be some more complex and unique issues that require a little more time to unravel with the support of our Medicaid eligibility coordinators. So the care manager's role here, as we all know, having active Medicaid, it's a requirement for CCO services. And of course, we know if somebody's Medicaid is inactive, it's going to impact so many more things for that person. It's going to impact waiver services that you all are providing. It could impact medical providers, their ability to access care, needed medications. So it is the number one important thing that we need to be on top of and ensure that that Medicaid is staying active and there is no disruption. So for that reason, reinstating Medicaid, regardless of that reason, really becomes the care manager's primary role during any period of Medicaid activity. That means until the Medicaid is reinstated, the care management support becomes limited to those activities and those tasks that are specific and directly related to reconciling the issue and reinstating that Medicaid for the person. Although it's rare, we do encounter situations where the person or their family ultimately decides that they don't want to or they're not willing to take the steps necessary to reinstate Medicaid. Sometimes that's related to paying a spend down or an overpayment. Once that is confirmed with the person or their support, we do have to disenroll the person from the CCO at that point, and the care manager would notify providers that the person has requested no longer to receive services with us. They weren't interested in maintaining their Medicaid, and that a disenrollment will be occurring, in the coming month or two. So it should be noted that depending on the reason for the Medicaid inactivity, there is no guarantee that reinstating the Medicaid will be retroactive back to the date that Medicaid became inactive. Sometimes there, I think, is an assumption that, okay, the Medicaid went inactive. Once it gets, reinstated, it'll be fine. We'll be covered over that full period. But really, is something that we can't guarantee because it is going to really depend on the reason. So for that reason, as providers, our recommendation would be you should consult with your compliance teams also to determine if it's appropriate to continue providing services during a period of Medicaid inactivity as we're all working together to support the person to reinstate that Medicaid so they can continue to receive all the wonderful services that we all collectively provide here. So that wraps up my portion of today's presentation. I thank you all for listening and your participation. And I am now going to hand it back over to Angie Monroe, who is going to introduce our next presenter. Thank you.
Thank you, Carolyn. You presented a lot of great information. I'd now like to introduce Andrea Emerson. Andrea is the Director of Medicaid Eligibility and Benefits with CCANY. She supports care management by providing monthly seminars on a variety of benefits and entitlements topics. And she holds office hours so care managers can drop in and ask questions. She really is the expert on all things benefits and entitlements. Andrea also recently became a certified work incentive practitioner through Cornell University's program. So she can now assist members in receipt of disability benefits return to work. In addition to that, Andrea is the proud mother of a precious little girl who is supported by LIFEPlan. We'll see the little golfer in an upcoming slide. Take
Thank
it away,
you.
Andrea.
Good afternoon, everyone. Thank you for having me. I'll be starting by going over some important information pertaining to Medicaid recertifications, and then we'll be reviewing the disability programs that Social Security offers and how work impacts these benefits. As Carolyn stated, anyone who is not in receipt of SSI benefits needs to recertify their Medicaid on an annual basis. Recertification packets are generated by the end of the 9th month of the case authorization. For example, if the authorization period is January through December of 2025, then the renewal packet will be generated at the end of September, and members should receive it in October. The due date is printed in bold on the first page of the packet. It is very important that these are returned timely and well in advance of the due date. Next slide. It's also very important that Medicaid and all benefit entities have the correct address on file for the people that we work with. Correspondence for these entitlement programs is almost always handled through the mail, so if someone moves, it needs to be reported as soon as possible. Recertification packets review all information provided at the last renewal. If there are any changes to this information, it needs to be noted in the appropriate section. A common change is becoming eligible for third-party health insurance, such as Medicare or the parent's employer's insurance. In these cases, a copy of the new card needs to be attached. Medicaid does need to know about other health insurance plans because sometimes they will reimburse families for the cost of their monthly premium. Once the packet is submitted, it's reviewed by Medicaid, and a notice of decision should be received by the end of the following month. If a notice of decision is not received, the care manager can assist by contacting Medicaid. Whoever completes the recertification should always keep a copy for their records. As we know, things can go missing in the mail, but it's also helpful to refer to the prior year's recert when completing the next one. We also encourage our care managers to upload it into CX360 for these reasons. Next slide. Next, we'll go through the recertification documents that are required for people under the age of 18. First is obviously the completed and signed recertification packet. Next, we want to include the NOD if they're affiliated with the waiver. Even if you believe Medicaid to already have this information, it is best practice to include it with each and every recert. The signed HIPAA form and proof of income are also required. For members who have active Medicaid through the deeming process, they're still required to provide the parent's income information. Waiver of parent's income does not equal a waiver of providing the information. This is a requirement by the state. As we know, enforcement of these requirements has lacked during the public health emergency and the unwind, but this is not a change. Parents have always had to provide information about their income, both at application and recertification. If the child has income of their own, such as survivor benefits or child support, that income cannot be waived, and proof must also be provided during the recert, along with proof of resources. Next slide. For people who are over the age of 18, all the same documentation is required, as well as proof of their income, especially if they're working. For resources, if someone has an ABLE account or a trust, the value is excluded, but proof of the account with current balance information is still required. New York City residents are encouraged to use their Access HRA accounts to complete their recerts, which is a more simplified version, especially if there are no changes from the prior year. Next slide. Next, I just wanted to go over the 2025 rates pertaining to Medicaid. So this year, the income limit for an individual residing in the community is $1,800 a month. If someone is working and they lose their cash benefit due to wages, they can still maintain their Medicaid through a program called 1619B. If and only if they maintain eligibility in all other areas, including the resource limit. Under this program, somebody can earn up to $64,000 and change annually. If someone exceeds that income limit, they could then enroll into the Medicaid buy-in program, which has an even higher income limit for people who are working that want to maintain their Medicaid. This program allows workers to earn up to $75,385 annually. And the resource limit this year for Medicaid is $32,396. Next slide. Next, we'll talk about managed care plans through Medicaid. Mainstream managed care plans are compatible with the services that we provide. Now, all counties in New York State are considered mandatory managed care counties, which means if someone has straight Medicaid with no other insurance involvement, Medicaid is required to enroll them into a managed care plan. For people on the OPWDD waiver, they have a code 95 on their eMedNY reports, which represents the waiver. Having that code allows them to voluntarily disenroll from a managed care plan if they've been enrolled and they don't want to be. Next slide. Next, we'll switch gears and talk about the needs-based disability program that Social Security offers called Supplemental Security Income, or SSI. This is for people who do not have a significant work history and have low income and resources. They must also be aged, blind, or disabled to qualify. As we already said, people who are approved for SSI do not need to recertify their Medicaid. It's done automatically each year. Because SSI is needs-based, it is capped. So the maximum amount that someone can receive this year on SSI is $967 monthly. This does not include the New York State supplement that they're also eligible for. Any other source of income will reduce the benefit amount. Different income is counted different ways, but some types of income that are counted are child support, wages, veterans benefits, adoption subsidies, foster care, or kinship guardianship assistance. Resources also play an important role in eligibility. The individual resource limit is $2,000, and for couples, it's $3,000. Unfortunately, the resource limits haven't changed for this program in over 30 years, but there is a lot of advocacy going on currently with legislators in an effort to increase this. Examples of countable resources are things like bank accounts, life insurance policies, stocks, bonds, and mutual funds. Property is counted, but like Medicaid, SSI excludes the value of your home if it's your primary residence, regardless of its value. Same with a vehicle. If someone owns one vehicle, the value is excluded entirely, but if they own more than one, the one of higher value would be excluded, and the second or third would count dollar for dollar and would need to be below $2,000. Someone's living arrangement also plays an important role in the amount that they'll be paid by SSI. If someone is not meeting their fair share of household expenses, their SSI payment can be reduced by up to 1/3 of the federal benefit rate, which is $322 a month. So that's a pretty big hit. On the same note, if someone is institutionalized, such as being in the hospital or a nursing home for more than 30 days, this needs to be reported to Social Security. This is because their benefit will be reduced to $30 a month until they return to the community. Next slide. And this is my favorite slide because this is my daughter. SSI is available for children and spouses. For children under the age of 18, their parents' income is counted when determining eligibility for the child, which is why attaining age 18 is so important, because then this process ends and Social Security only looks at the individual's income and resources. If someone is married, their spouse's income and resources are considered. If two SSI beneficiaries get married and live together, they become eligible for the couples rate, which is actually $483 less than if they each collected the individual rate. So this is really important information for people to know if they want to get married and they're both on SSI. Next slide. Now we'll look at how work impacts SSI. So Social Security uses a formula to determine the amount of someone's countable income. More than half of their wages are excluded when determining the benefit amount, which really gives people an incentive to try and work if they want to. I wanted to show an example of how working while collecting SSI is more advantageous than solely collecting SSI. So if you have someone who is working and grossing $1,200 a month in wages, only $557 of the $1,200 is considered countable. Once the formula is applied, this person would still be eligible for over $400 a month in SSI, making their total financial benefit over $1,600 a month when combined with their wages. So this is an additional $642 every month than if they were only collecting the maximum benefit rate of $967. If someone is working, it's very important that they report their wages each and every month to Social Security. This prevents them from being overpaid and owing money back to Social Security. If someone wants to work, we shouldn't discourage them from doing so. Have them meet with a benefit specialist ahead of time to review their career goals and desired pay to see how it will impact their benefits. Always inform them of the risks involved, but leave the decision to them. And remember, if SSI remains in pay, even if it's only $10 a month, that will keep their Medicaid automatically active. Next slide. Now let's go over a different disability program that Social Security offers called Social Security Disability, or SSDI. This is another program offered for people who have a work history and earn enough working quarters to be insured. This is considered an earned benefit because it's based on the worker paying FICA taxes. Therefore, the amount someone receives is based on how much they earned, so it's different for everybody. Next slide. The next program, which is also an earned benefit, is DAC, or Disabled Adult Child Benefits, also referred to as Childhood Disability Benefits, or CDB, or some people call it SSD on a parent's record. This is considered an earned benefit because it's based on their parents' earnings. The child first becomes eligible at age 18 if their parent is receiving retirement benefits, Social Security disability benefits, or has passed away and worked prior to their death. The parent has to be in one of the qualifying categories in order for the child to be eligible. Therefore, many people start on SSI and then they transition over to the DAC program once their parent falls into one of those categories. Next slide. So here we'll look at how work impacts the Title II disability programs, which includes SSDI and DAC. The income limit for Title II is SGA, or Substantial Gainful Activity. SGA has a numeric value that changes every year with the cost of living adjustment. This year, the gross amount for non-blind people is $1,620. And for people whose primary diagnosis is blindness, it goes up to $2,700 a month. Next slide. Which means that people can earn up to SGA and still collect their entire disability check. For example, if you have someone who collects $1,350 each month in DAC benefits, and they're working and they're grossing $1,550 a month in wages, their total financial benefit each month will be roughly $1,500 more than it would be if they didn't work because their earnings are below SGA. And this is without any work incentives applied. So there's the potential for even more income to be earned before it affects the disability payment. Next slide. So what about insurance? For people on SSDI and DAC, they become eligible for Medicare after 24 months. This is automatic and does not require, well, I shouldn't say that. In a perfect world, it doesn't require the member to contact Social Security, but it's done at the initial application, and then 24 months later, they should get their cards in the mail. Becoming eligible for Medicare does not end their Medicaid. They can absolutely have both insurances without any impact on the services that we provide. In this situation, Medicare would become primary and Medicaid secondary. There is a cost associated with Part B for Medicare, and that current cost is $185 a month. If you have someone who's having a hard time paying this, they may be eligible for the Medicare Savings Program, where the state pays the Part B premium for them. People can inquire about the Medicare Savings Program at their local Medicaid office, and there is an income threshold in order to be eligible. And I just wanted to mention a helpful hint. I know these programs can be confusing, so if you're not sure what program somebody is on, if they're under the age of 65 and they're on Medicare, that's an indication that they're collecting a Title II benefit, so either SSDI or DAC. Next slide. So to recap, I wanted to quickly compare the different disability programs. So we have SSDI and DAC versus SSI. SSDI and DAC are often referred to as Title II benefits, where SSI is referred to as Title 16. If you're on Title II, you automatically become eligible for Medicare health insurance after 24 months. And if you're on SSI, you automatically become eligible for Medicaid. On Title II, the benefit amount is based on earnings, either the workers or their parent. And on SSI, the benefit amount is capped. This is because Title II is considered earned and SSI is needs-based. There is no resource limit imposed by Social Security on Title II, but since everyone that we work with is on Medicaid, they must adhere to Medicaid's resource limit. Everyone on SSI, however, must keep their resources below $2,000. If someone is working, the income limit for Title II is SGA, where SSI uses a formula to determine the amount of countable income. So wages are counted slightly differently between the two programs. And as far as marriage, if someone is a DAC beneficiary, their benefit will end if they get married, unless, because there's always something, unless they're marrying another Title II beneficiary. If someone on SSI gets married, their spouse's income and resources are considered when determining their eligibility. Next slide. And lastly, how long can someone receive money on all of the programs that we talked about today? Although many people collect these benefits for the duration of their life, they're not necessarily guaranteed, meaning regardless of someone's disabling condition, every single person on these programs is subject to periodic medical and non-medical reviews. A lot of people question why they have to complete a medical review if they have a chronic condition, such as cerebral palsy, but it is a requirement for everyone. These reviews are initiated by Social Security and usually always sent by mail. And that's everything I had, Angie. So with that, I wasn't sure if you wanted to open it up for questions or go right into Jennifer's presentation.
We do have a few questions in the chat, not too many. So I'm going to start with the coordination of benefits related questions. So there are two in here. The first one is, if the parent has insurance from work, parent of a child, is Medicaid primary or is the secondary, are they the secondary?
So Medicaid is always the payer of last resort. So any other insurances are going to be billed first prior to Medicaid. If they also have Medicare, then it's going to depend on how many employees the parent's insurance has. If the parent's employer has more than 100 employees, the employer's insurance is primary, then Medicare, then Medicaid. If they have less than 100 employees, Medicare becomes primary, then Medicare, then the parent's health insurance, and then Medicaid, but Medicaid's always last.
Great. So then the next question is, what happens when members neglect to fix coordination of benefits with Medicaid? For example, a patient no longer has a primary insurance, but Medicaid still has the primary insurance on file. Does the liability fall on the facility or provider? It says we are told we should never bill patients on Medicaid. Well, I'll let you. It's so basically, if somebody has not notified Medicaid of their, end of their other insurance, how can they go about doing that? And where is the liability as far as billing goes?
I mean, it's always a collaborative effort. I would say that ultimately it's going to obviously be reported minimally on an annual basis during the recertification. But if you have someone who's not submitting a recertification, then you should absolutely be notifying Medicaid as soon as possible so they can remove that insurance. As far as whose responsibility that is, ultimately it's the care managers to make sure that it's done. But again, it's a conversation between the team to see who's going to take the point on that. But if we all work collaboratively together, then, I mean, it's a quick call to Medicaid to notify them.
All right. Let's see. So the next question is related to children and parental deeming. If a child has Medicaid and the Medicaid waiver, the HCBS waiver, how do you know that they have been properly coded so that if a parent's income increases on the recertification, Medicaid knows not to take that into account?
But it's inactive?
Nope, just a general recertification question.
Oh, okay.
So, yeah.
So if the income has increased since the last recertification, you're saying?
Yeah, but I think, Andrea, Megan's question is about if the parents
parental deeming. Yeah.
increased.
They asked how to ensure that Medicaid has coded the coverage properly to ensure that they don't count any parental income or parental income changes.
Okay, so at the time of recertification, that's why it's so important that we always provide the income information, even if it's a deeming case. We know it's not going to count against them, but Medicaid still has to properly apply those exclusions. So they have to have the income information. And if it's increased since the last recertification, we want to make sure that a copy of the notice of decision is also submitted so that they know that deeming applies.
There is an inactive Medicaid question. A client whose Medicaid has been inactive since August. The care manager, the only updates from the care manager is that it's been submitted and they're waiting for it to be reviewed and approved. The provider asked if there are any suggestions that they can take for next steps to try to resolve it.
Do you want to answer that, Carolyn?
I mean, it's so broad, without details of what the situation is, is that a lapse? Is it inactive because there's a spend down? There could be so many reasons. So to be able to give next steps, I don't think we could really give that here.
Yeah, it is a lapse in coverage. We just got a clarifying.
A lapse in coverage. Okay.
Yeah.
So I mean, depending on why that occurred, how that occurred, and why it's taking that long, I would really, to give you information on next steps, we'd really have to know kind of the details of what is happening as to the lapse, like when it was submitted, why the lapse occurred in the first place. I mean, it's something, you're free if anybody has a very specific question about somebody we mutually serve and you are on the consent to receive information, I would say if you're looking for more details, you're welcome to call our customer service center. That'll get ticketed to the appropriate team to get back to you if you're looking for more information. So if it's like a very specific question like that about a mutually served member, that would be my recommendation.
I just put that information in the chat also.
Great.
Yeah. And Caitlin says thank you. So then I have a question about work. If someone is working, they're receiving waiver services, including STEM, and they want to pursue full-time employment or employment which would cause them to exceed resource and income limits for Medicaid, SSI, or SSDI. What does the process look like to get them into the 1619B program or otherwise preserve their services?
So that's a great question. The importance of the 1619B program to remember is that the person has to still qualify for SSI in all other areas, including being under resources. So if you removed wages in all other areas, they would still be eligible for SSI. So in this case, they may not be able to maintain their Medicaid through that 1619B program if they're over resources. But of course, there's accounts that they have options to establish an ABLE account or a trust if they're, depending on how much they're over, to protect those resources so they can maintain eligibility and still be under the resource limit. But as far as the process, there is something that happens prior to 1619B going into effect called 1619A. So we touched on how wages are counted differently for the two programs, and SGA, that income limit is a bit lower than the break-even point for SSI, which just means that that's how much they earn. And after that formula is applied, it would result in a zero cash benefit. So once someone is working, they're on SSI, they're consistently over SGA, Social Security internally is flagging that record to say, okay, they're getting close, they're at 1619A. The person would have no indication that this is happening. Social Security doesn't necessarily notify them. But once they go over that break-even point, then Social Security will contact them about next steps to maintain Medicaid through the 1619B program. They still have an active record through Social Security, which keeps their Medicaid active automatically. And you would get something in the mail.
And then so I'm going to just add to the question, if they're no longer eligible for 1619B, but they are working, they could then go for MBI, correct?
Exactly. So MBI, WPD, or Medicaid buy-in for working people with disabilities has an even higher income limit than 1619B. After a certain amount, you could incur a premium, but you can still maintain Medicaid without paying a spend down up to that $75,000 roughly annually. So there are a lot of options for people who want to go back to work before it really starts to jeopardize their benefits.
All right, great. Those were the only questions so far. So I will turn it back over to Angie, and we will get any questions, that you want to ask that maybe you didn't think of. We can always get to them at the end of the presentation.
Great. Thanks, Megan. Thank you, Andrea. Now, please welcome Jennifer McCullough. She's here to speak to us today about the Supplemental Special Needs Trust that will be launching in the coming weeks. And it's a good time to talk about it right after that question that Andrea just answered.
Thanks, Angie, and thanks everyone for having me. I appreciate it. As Angie just mentioned, this Supplemental Needs Trust has not yet been launched. We're just finalizing a few more details. We do expect to launch it this spring. It is an asset protection trust. It is not a spend down trust at this time. So we will just be starting with the Community Trust 1 coming up. So without further ado, I'm going to jump right into it. If you could advance the slide. Thanks. So a supplemental needs trust is a type of trust that allows individuals with disabilities to set some money aside for personal use and enjoyment, life enrichment, and the funds are protected and not counted towards SSI or New York State Medicaid or any other New York government benefits. The nice thing about a supplemental needs trust, community supplemental needs trust, is that anyone who meets the Social Security definition of a disability can apply and be eligible for the trust. And our trust in particular, anyone across New York State, it doesn't have to be an ACA member. It can be anyone throughout New York State who meets that Social Security definition of a disability. Next slide, please. So there's three main types of supplemental needs trust. The first is a first party trust. It's also known as a self-settled or Medicaid payback trust. It's established with the beneficiary's own funds, and they must choose a trustee to manage the trust. There's a third party trust that's funded by anyone other than the beneficiary. And again, a trustee does need to be chosen or hired. And then there's the trust we're talking about today, a pooled or community trust. It can be self-funded or gifted by another. It can be an inheritance or a settlement. It can be retroactive benefit payments. and that is administered by the nonprofit organization acting as the trustee. Next slide, please. So supplemental or special needs trust, they can provide a source of income for the individual so that they can maintain their benefits and still supplement the goods and services that are already provided by benefits. First and third party trusts, as I mentioned, must have a trustee, and they have the fiduciary responsibility to act on the best interest of the beneficiary. That can be really overwhelming for some people. So even if somebody does have a family member that could be a trustee, they may not want to. They may not want to get involved in that. And professional trustees can be expensive. In the case of a community trust, the nonprofit organization acts as the trustee. These can be used for a variety of goods and services, like I said, to supplement what they may already be receiving by government benefits. Next slide, please. So how do they work? These trusts are intended to supplement and not replace the goods and services that are provided by government benefits. And that's one of the reasons why these trusts are managed by a board of managers. I would like to add that the trust that we are launching is managed by a completely separate board of managers. It's comprised of attorneys, financial advisors, folks that have been in the industry for decades that understand the regulations as they pertain to supplemental needs trusts. So as requests for payments and disbursements come in, these are reviewed by the board and approved so that they can make sure it's not going to impact or put your benefits in jeopardy. Disbursements must directly benefit the beneficiary and only indirectly benefit others. So I use the example of travel costs. If somebody is taking a trip and they wish to have a companion on the trip, that's a perfect example. They could pay for the companion's travel costs. However, they could not just withdraw cash and give it to somebody because that would act as cash and would impact their asset caps for the government benefits. And the next bullet there, an SNT cannot give money from the SNT directly to the beneficiary to make purchases on their own. Again, that would count as income and would impact their benefits. So instead, if somebody does wish to make a purchase, they would simply email in or mail in, whichever is easier for them, the disbursement request. It would be reviewed and approved quite quickly. And as long as everything is included in that request, such as an invoice, making it very clear that it's for the benefit of the beneficiary and an exact amount, that would be dispersed right away. Next slide, please. First party and community SNTs are especially helpful for, again, people that are applying for or already have New York State Medicaid or SSI and do not meet the restrictive asset limits. So if somebody already has the benefits, but they're coming into an inheritance or that retroactive payment, they can be proactive and have that money directly deposited into the trust so that it doesn't impact or put their benefits at risk. Or somebody who's getting ready to apply for benefits and they're concerned that they're not going to meet the limits, they can put that money in the trust. The trust, because the way these work is the documents, and this is something we're dealing with right now, all of the documents are pre-approved by the Social Security Administration. They're very standard. So the application process, as long as all the boxes are checked and everything's filled out completely, it's very quick and easy to become eligible. As long as everything is submitted in entirety, you can be approved within a week. Next slide, please. So some people are a little concerned when they hear the word pooled trusts. So it is important to know that everyone maintains their own sub-account. They're not sharing funds. So they maintain their own account of trusts, and then all of the sub-accounts are pooled together for investment purposes. And this allows us to lower the administrative costs to the beneficiaries. There's a wider array of investment opportunities, greater diversification, and reduced risks. As I mentioned earlier, the documents are already drafted and approved, so very quick and easy to set up. And it is managed by individuals very well versed in special needs planning, the changing benefit rules, and local services. Next slide, please. So if a beneficiary has no living parent, grandparent, or any other family member that may wish to act as the trustee, the pooled trust is a really good option for them. It's an affordable option. So to set up some of the other trusts to go through a financial institution or a financial advisor, it can be incredibly expensive. Individuals who already have the benefits and may be coming into inheritance, again, this will not put their benefits at risk. Next slide, please. So I won't read through all of these, but you can take a look and get an idea of what S&Ts can cover. So as we mentioned, you just don't want to be duplicating efforts with Medicaid or SSI for what you are paying for, but they can supplement those items. You do need to be careful with any expenses that are regarding your shelter, because that can reduce your SSI benefit amount. Again, that's something that our board of managers would be very well versed in and would look out for. Next slide, please. So ABLE accounts are also a very viable option. And I just wanted to provide this side-by-side comparison. So ABLE accounts can be opened by the person with a disability. They can manage their own account or have an authorized representative manage it for them, while the community S&T, it is opened up with the beneficiary's own funds or anyone else's. But the nonprofit organization does the management. They understand the tax laws. They provide the proper documents come tax season and take care of all that for the individual. With an ABLE account, the disability onset must be prior to the age of 26. And with the S&T, they just have to meet the Social Security definition of a disability. There's only one ABLE account permitted per individual, but you may also have a supplemental needs trust, and you may have multiple supplemental needs trusts. The maximum amount annually for a contribution to an ABLE account is $18,000. There are no limits on an S&T. And if the account grows to $100,000, SSI will be suspended for an ABLE account until the account balance drops below that level. S&Ts do not have any maximums. The maximum holdings in an ABLE account are $520,000, no maximums with an S&T, and it's managed, excuse me, managed by the individual with the ability to utilize a debit card. That's great for independence and ease of use. As we have mentioned, the trust is managed by a board, and they maintain the records. They follow all government regulations and produce the necessary tax filings. Both are very easy to set up. They can both be set up very inexpensively. The trust that we are preparing to launch in the coming weeks will be opened with as little as about $250 to $300. Next slide, please. So that's about it. That's kind of a high level of what we're doing. Again, we're getting ready to launch this. More specifics will be out in the coming weeks. Do we have any questions?
Yes, we do. So we have two questions. The first one is, can you explain what a community trustee is?
The trustee would be, so there's co-trustees. There's the board of managers that oversees the trust to make sure that benefits are not being impacted and all rules and regulations are being followed. And there's the bank where the funds are being held. That has not been finalized yet. We are working with the Bank of Canandaigua at this point, but again, not finalized. So they are co-trustees.
Okay. Let's see. So this is, I think, a continuation, basically getting ready to launch. Does that mean that we are, so I guess explaining who is launching the trust. So it's a, yeah.
So ACA is getting ready to launch the trust under their parent organization of CCANY. But again, anybody throughout the state that meets the requirement, the Social Security definition of disability can apply.
All right.
So an individual, for instance, who has dementia, but no other disability, that would meet the guidelines.
Right. Great. We do have some more questions coming in. So this is about Social Security windfalls. the time limit, the 9 months. Let's say someone gets an inheritance, but they need to have it under a certain amount. Social Security does allow the 9 months to spend a windfall. Does the community trust help to cover this?
Yes. So instead of rushing to spend that money down, you can just deposit that into the community trust. Again, it takes about a week to set up. So you're more than covered with that 9 months.
Great. In the case of a pooled trust, who makes decisions on behalf of any legal decisions about the expenses? Does the guardian have to sign a consent for every expense? If there's no guardian, who would handle that?
So that depends on how it is set up. So when applying for the trust, you can decide who the authorized representative is, and that if you this is kind of where the care management comes in to help a little bit, to explain that. It can be a little bit tricky and difficult to understand. So if they do decide to have an authorized representative co-sign everything, they can be documented as a signer for the individual, and they can submit the requests and handle it from there. But everything that comes through is reviewed by the board to make sure it's meeting all the requirements and not putting anybody in jeopardy.
And I'm going to elaborate because they did mention everyday expenses. And I would say that based on, what you've told us in the presentation, that might be a situation where a person might benefit more from having an ABLE account if they need some access to some kind of money for regular, for an everyday unexpected expense, right?
So I will add, yes. Additionally, however, you can, instead of submitting a disbursement request, waiting for it to get approved, waiting for a bill to be paid, that can be difficult, right? Somebody needs to shop around for flights. They're going on vacation and they have a great deal and they want to buy it then and there. You can purchase with a credit card and then turn around and submit proof of the purchase, show a receipt that very clearly identifies that it is for the benefit of the beneficiary, and payment information, and then the trust can make the payment to the credit card.
The next question, is there a fee, and if so, how does paying the fee work?
So that's some of those details are still being finalized, and as soon as that's done, we will publicize the fees. There will be some monthly fees. It depends on how much is in the trust. So it can be as low as $20 a month, and if there's a good amount in the trust, it may be a small percentage based a small annual fee broken down monthly. But those final details have not been determined yet. To open the trust, we are looking at about $250 to $300 to open it. Out of that money, it looks like only about $100 to $150 will be the enrollment fee. The rest is so that you have a buffer in there to take care of any next month's fees.
Great. Next question. If someone has a nonprofit as direct payee for Social Security benefits, would they be better suited for a community trust for their resources or an ABLE account? What should they weigh in that case to make that decision?
I'm not very well suited to answer that question, to be honest with you. Andrea, you might have more knowledge on that.
Sure, I would take a look at how much the individual is going to potentially be contributing each year, because there is a contribution limit with an ABLE account where there isn't with a trust. So it's going to depend on their financial situation to see which direction they should go. And then I just wanted to make a point about the windfall question. That 9-month exclusion only applies to retroactive Social Security benefits. So if somebody is due back pay, then Social Security gives you 9 months to spend that down. If someone's on SSI and they get an inheritance or something like that, that starts to count immediately. It counts as income in the month it's received, and then a resource after in every month that exceeds the resource limit. So even more reason to set up a trust quickly so that you don't lose your benefits too
It's a great point, Andrea. Thank you.
And then the last question right now, if anybody else has questions, we still have time if you want to add them. But what happens to the unspent sum of the trust after the death of the person?
I'm glad you asked that. So yes, with community and pooled trusts, That's called a remainder fund. Any remainder funds after the death of the beneficiary does stay with the 501c3, with the charitable organization. It is not used to pay any employees or any operating expenses. It goes into funding to further enhance the lives of the people that we serve.
Great. And Andrea, someone in the audience said that they did not realize there was a difference, and thank you for pointing that out. That last point that you made about the windfall amount and inheritances. So,
A lot of people, it's because so many people say windfall, and it means two different things. So I always want to make sure that we decipher that.
yeah. Next question. If we assume the person is not going to contribute more than $10,000 to an account annually, what other considerations would help them decide which type of account would be better suited for them?
It's
I mean,
really
it's
going
really
to come down
Yeah,
to,
go ahead.
oh, sorry, Andrea, go ahead.
I was just going to say the exact thing that you were going to say. It's a personal choice. I mean, there's with an ABLE account, you can use the money for the direct benefit of the person setting it up. With trust, there's a little more red tape around there. So if they're only going to be contributing $10,000 a year, that does not exceed the contribution limit. So it sounds like that would be a good option for them, but ultimately it's their choice.
It looks like we have another question coming in, but I think they sent the question too soon. I just want to give them a second. Let me just make sure I did not miss anything. Will the presentation be shared? Yes, we are going to share the recording on our website. So we'll be sure, and I'll be sure to send that out and make sure that all the attendees have a copy of that.
May I just make one other point going back to Catherine's question? I was rereading it and I realized that she also asked about SSDI, and I only answered it from an SSI perspective. So I just want to make sure if you have someone who's in receipt of Title II disability benefits and they think that they're going to exceed SGA, there's a whole other world of work incentives that are available to them. There's the trial work period, we'll just go through quickly, where they can exceed SGA for 9 months. That does not have to be consecutive, and that's over a rolling time frame of 60 months. So they have 5 years to use their 9 months for the trial work program. Even after that, after they use their 9th month, where they're completely over the SGA and they're not penalized, then it starts an extended period of eligibility, which is another protection for the worker. That runs 36 months consecutively, and that protects them from having their benefit terminated during those 36 months. So if they earn over SGA during that time, their benefit will cease but not terminate. There's still a grace period that they get. There's so many things that can keep them in pay, have their Medicare active, and continue to collect wages. So there's a whole world to explore there. I just wanted to make sure I make that point.
Yeah, that's great. And I know that's very confusing for a lot of people, the different work programs, because there really are a lot of different ways you can still maintain your benefits while working. That looks like it wraps up our questions. So I think that I will turn it back over to Angie.
Thank you, Megan. Thank you to all of our panelists and for everyone here with us today. Great questions. This concludes today's webinar. We would love to hear your feedback, and we'll share a post-event survey with the email you provided at registration. We also welcome your suggestions on future webinar topics. If you have any innovative practices to share that would be beneficial to others in the field, please let us know. As a reminder, the directors of provider relations are available to assist when you have questions or concerns. Coverage areas and contact info for each of our the directors of provider relations is available on the provider page of both CCO's websites. We also encourage you to use our customer service centers for each of the individual organizations for information and document requests. Thank you all and enjoy the rest of your day.
Thank you.
Bye-bye.
Thank you.